Dear colleagues, we are about to start. Please take your seats. First of all, I would like to thank you. You see, I have to talk to the entire audience, therefore I turn around in order to make sure that I do not turn my back to some of you. First of all, I would like to thank the Department of Healthcare for a possibility to hold our session here. We are going to talk about one of the most important and intriguing matter related to neurology and epileptology, an issue that we counteract on a daily basis or at least on a weekly basis. And as a rule, this is the situation where we have no answers because Myoclonus, and we are going to talk in detail about it. So Myoclonus is a sign, a neurological symptom that can be observed with different diseases. And unfortunately, not always we are able to give a correct diagnosis. And as we will see today, not always we are able to offer adequate therapy. Therefore, today we have the best experts, and it is my great pleasure to introduce Professor Reta Kalvianin. Reta is one of the leading neurologists and epileptologists worldwide, and it is a pleasure for me to keep in touch with Reta for many years. Professor Kalvianin is the director of the Epilepsy Center at Kuopio University in Finland, and this is one of the leading centers worldwide. She is the president of the Finnish Anti-Epilepsy League, and she's also the professor of neurology at Kuopio University. It is an honor for us to have her here. Her articles are published in the best medical journals worldwide, and she's one of the most renowned specialists when it comes to Myoclonus worldwide. So again, it's a pleasure for us to have you here, and I pass the floor to her.
Thank you very much. It's my great honor to be here today, and I thank the organizers and also, of course, my great dear friend, Professor Alla Kukt, for the invitation here. So I'm coming from Kuopio, from the Eastern Finland, from the University of Eastern Finland, and then from the Kuopio Epilepsy Center. We also have a so-called FinHealth service for patients from abroad, and very often see also patients from Russia. We also belong to the European Reference Network for Rare and Complex Epilepsies called EpiCare, and during that do a lot of collaboration also regarding research and service for these very difficult epilepsies and also symptoms in rare neurological disorders. These are my disclosures. And I also work very actively in the European Academy of Neurology, which is one of the organizations where we have also collaborated a lot together with Professor Kukt. So coming back to Myoclonus. So Myoclonus is a very general symptom. Myoclonus is a brief involuntary twitching of muscle or group of muscles, and it's only a very general medical sign, and it's not a diagnosis of a disease. We need to then evaluate and really make a really diagnosis of the underlying disease behind the myoclonic twitches. Myoclonus can be positive when the muscle contracts, or then there can be brief lapses of contraction, which is called then negative myoclonus, which is also a little bit more difficult to notice, but is as important sign of a disease than positive myoclonus. The subtypes of myoclonus are then defined according to the origin of the symptom. So myoclonus can be cortical, subcortical, spinal, or peripheral. And these are not necessarily very easy to differentiate. But there are some clinical characteristics that differentiate these. We can look at whether the myoclonus is spontaneous, whether it's induced by action, so movement, or whether it's, for example, stimulus sensitive. And then we can study the myoclonus electrophysiologically. So, for example, there are certain electrophysiological characteristics that differentiate cortical myoclonus. We can usually see some EEG changes apart from EMG changes in the cortical myoclonus, and the burst duration, for example, is longer in subcortical and spinal myoclonus compared to the cortical and then again peripheral myoclonus. And in peripheral myoclonus especially, there are also other EMG changes in addition to the burst seen, and so on. But it's very important to try to find out on what level of the nervous system the myoclonus originates. But it's not, as said, easy. But that influences to the finding of the etiology and also to the treatment to a certain extent. So there's a diagnostic myoclonus workup, and it starts with the electrophysiological testing and trying to differentiate the anatomical substrate, and especially the duration of bursts is important, and also the involvement of muscle groups. And then sometimes in the cortical myoclonus, somatosensory evoked potentials are important. And also in cortical myoclonus, even though in the EEG there doesn't seem to be a very clear correlation of finding a spike or epileptic bursts, you can use so-called back averaging of simultaneous EMG and EEG and sometimes find a spike before the EMG when you do this kind of back averaging analysis. And then after electrophysiological study, then you enter to the etiological studies, laboratory tests, imaging of brain and spinal cord or with magnetic resonance imaging, and then also sometimes genetic testing. And there are, as I'm going to describe to you, there are a huge amount of etiological possibilities behind different kind of myoclonus. But first we go to the myoclonus rating scales. How can we evaluate the myoclonic jerks? Historically, there has been one myoclonus rating scale described by Truong and Fan, but then at the moment the most used myoclonus rating scale is described by Stephen Frucht, which is called Unified Myoclonus Rating Scale, UMRS. And basically both these scales and how myoclonus nowadays should be evaluated is by video recording. So you investigate the patient and at the same time you yourself video the patient, or your assistant will video the patient, and then afterwards you assess the video when you have time to really look at the frequency of myoclonus and also the amplitude of myoclonus. So to make the UMRS scale, it takes about 15 minutes, not more than that. So it's quite useful also in basic clinical work. And there are 8 sections in that compared to the little bit more simple Truong and Fan scale. So if we look about the UMRS, it's quite comprehensive. There is a patient questionnaire where you can ask speech, reading, handwriting, eating, drinking, swallowing, and so on this kind of functional abilities of the patient. Very good questionnaire, in fact, and useful, and we use it a lot in our clinic. Then there is this part which is videoed, where first of all you can test stimulus sensitivity, whether stimulus, different kind of stimulus like threat and sound, very high sound, jaw jerk, pin prick, and finger and toe flick, and different kind of reflexes will induce the myoclonus. And then you video the patient in rest and look whether there is myoclonus in rest or at rest on upper and lower face, neck, trunk, and limbs. Then there is the part where the patient moves him or herself, so this is myoclonus with action, which is, I think, the most important part. So if you don't have time to do anything else, you should look at this myoclonus with action. So eye movements, neck movements, trunk movements, finger to nose, heel to shin, arising, standing, and walking, whether the patient has myoclonus with action. Then you can perform also a couple of functional tests, like ask the patient to show his or her handwriting, spiral drawing, pouring water, and eating soup with a spoon, sort of pretend to eat soup with a spoon. Now we are going to look at a couple of videos from these various tests. So this is action myoclonus, and the patient has progressive myoclonus epilepsy type 1, EPM1, which is the Unrecht-Lundborg disease, which I'm going to talk about later more. But here you can see the finger to nose test, and there is remarkable, I would say, severe action myoclonus in this patient. And this is part of the UMRS scale, which she is doing now, but very good image of myoclonus. Now, this is one of the functional tests, again describing actional myoclonus, but also showing how severe myoclonus can be. And the next video, we go to the next one, and this is then reflexes. This is a patient still with EPM1, but a different mutation, so he has more severe phenotype than the normal EPM1. So already when I touch him or do the reflexes, he gets myoclonus. And now there's a lot of sound here, but my high heels are clapping on the floor here, and also the sound, only the sound of my high heels makes him the myoclonus. And the next one, now we can see negative myoclonus. So this is again a different mutation in a progressive myoclonus patient, and now you can see how little bit there's lapse of muscle contraction. So this is negative myoclonus again a little bit. So he could also instantly fall down with the like now. He can now stand, but there's also danger that he falls down with this negative myoclonus. So she again and again get these negative myoclonus lapses of muscle tonus, and that was negative myoclonus. And then the last one, which is not part of the UMRS scale, but this is to show you that not only motor action, but also cognitive tasks and stress can induce myoclonus. So here the patient is trying to concentrate on a neuropsychological task, and that that makes it more difficult for her to perform the neuropsychological task. Then this is then the spiral drawing. In a mild case, it's nearly perfect, and also the patient can write Helsinki, which is our capital, and then Finland, which are easy words. Then a little bit moderate case where there are more difficulties in writing and also spiral drawing, and then severe case where it starts to be already very difficult to draw anything or even hold a pen in the hand. Of course, all this takes a lot of time, and therefore, for example, Goldsmith and Minassian, 2016, made a sort of simplified Myoclonus modified version of UMRS. But my personal feeling is that you can use this kind of very simplified recording of intensity of myoclonus and functional and cognitive impairment, but you lose some of the details, and then it's very hard to compare, for example, the evaluation of different doctors and different evaluators between each other if it's so simplified, because it's very subjective already. So I would say that it's better to video and at least keep the videos and then evaluate the progression of the disease and also the treatment responses. So what we are now doing in our center, and we are trying to find out more objective ways to evaluate myoclonus, and one of our projects is that we wouldn't anymore rely on the 15 minutes in the office, but we would work towards home-based monitoring of myoclonus. One problem is that in these patients the myoclonus is also fluctuating, and it might be that it's more severe in the office, and it might be more milder during the daily activities or at home or otherwise. But it would be very important to have the whole picture, and therefore we need home-based monitoring. I think these couple of examples that I'm going to show you now also very well suit to this atmosphere where we are now, very modern techniques. So what we are aiming towards, we try to validate so-called home-based monitoring, real-world data, quantifying disease characteristics, in this case in the progressive myoclonus type 1 patients, but it could be any myoclonus. So at the moment we are developing algorithms to extract myoclonic features from electromyographic, so EMG, and motion data. So what we are doing, so we put wearable EMG and motion sensors to biceps brachii on dominant hand, and then extension digitorum to non-dominant side muscles. And patients keep these sensors at home, and then they keep also diary. And then we compare the data to UMRS, which is done at hospital. So it looks like this in real life. This is a real patient, and my nurse is putting these sensors on the patient before she leaves home, and then keeps this at home for a couple of days. And this is already in that way great that you can get feedback. The patient can get feedback from her own disease. And at the moment we are evaluating 7 mild, 7 moderate, and 7 severe myoclonus patients, and comparing the data with UMRS scoring. And what is clear, that you can see the myoclonus from these EMG recordings, that's clear. But then what we are now doing, we are our researchers in the physics clinic or department in the university, they are now providing an algorithm which could automatically then interpret the amount of myoclonus. So of course nobody can anymore no human can anymore interpret all the data that comes out of these kind of systems. The other thing what we are doing with videos only, we are trying to, because now if we make these videos that I showed you, somebody needs to look at them and evaluate and make the UMRS score out of the myoclonus that the patient has, the amplitude and the frequency. So that also takes time and human resources. But whether it would be possible to use computerized machine learning algorithms also for that purpose, and that's something that we are also doing. So this is, I think if you could click now the video also there, so that should work. I don't know. This one. Now. It doesn't work.
Будьте любезны, пожалуйста, вы могли бы нажать на картинку? Нажмите, пожалуйста, на картинку, чтобы запустить видео. Just a moment, I will try.
So basically, because we now changed from different computers. Okay.
Just a second, yeah.
Okay. It might work. Okay. It might have lost the ability to move, but basically the green figure moves now, and this is the same video that I showed you earlier. So now we are. It's possible with a sort of human pose and body movement analysis to make the machine learn to make the same analysis than the human being our doctor is doing with visually. And our first article is now going to be published about this machine learning algorithm comparing doctor, and they correlate very well. So probably in future it's going to be a machine that evaluates these UML scores and not doctors, which is great. And then we can also use these videos at home to more and collect more data. So there are challenges in evaluating myoclonus, and Unified Myoclonus Rating Scale, UMRS, is the only scale that at the moment has reached sort of recommendation status, but it has still challenges, and the future is 24/7 home monitoring and quantifying myoclonus with automated methods and machine learning, and that will change the accuracy of evaluation of myoclonus. So then shortly about treatment of myoclonus at this stage. Its most important initial step is to find out the cause of the myoclonus and eliminate the underlying etiology. And then if symptomatic pharmacological treatment is required, then it needs to be done. So if we go to the etiology of myoclonus, then we need to think about back to the origin of the myoclonus. So etiology of cortical myoclonus, all the degenerative cortical disorders can cause myoclonus, for example, Alzheimer's disease, Creutzfeldt-Jakob disease, and so on. All the infectious origins, like, for example, post-infectious encephalitis, herpes simplex encephalitis, and so on. And any kind of focal CNS damage. So it's very wide cortical symptom also, which sometimes is forgotten. Then the most perhaps widest etiology and group is so-called cortical, subcortical myoclonus. So there could be cortical components and also subcortical myoclonus. And in fact, the most epileptic syndromes belong to this group. So juvenile myoclonus epilepsy, eyelid myoclonia, progressive myoclonus epilepsies, and some of the mitochondrial diseases. And again, many degenerative basal ganglia disorders belong to this group, and then many metabolic disorders. So huge amount of metabolic diseases can cause also myoclonus as symptom, as a general symptom that need to be taken care of. So what is called myoclonic epileptic seizure is a myoclonus which is then related to an EEG finding where there is a generalized polyspike and wave activity related to the myoclonus, and so this is epileptic myoclonic seizure. And then we have subcortical, purely subcortical myoclonus, which then very often is induced by different kind of medication. So it's an adverse effect of medication. And here it's very important to remember that many anti-epileptic drugs that are sodium channel blockers and many GABAergic anti-epileptic drugs, but sodium channel blockers like phenytoin, carbamazepine, oxcarbazepine, and GABAergic drugs like vigabatrin and tiagabine from the older newer drugs, they can cause it, and many other drugs. Also benzodiazepine withdrawal can cause subcortical myoclonus. And then autoimmune diseases, including paraneoplastic diseases, can cause very severe subcortical myoclonus situations. And then lastly, we have also brainstem and spinal situations. Again, very huge variation of etiologies there. And now I think there would be a time for cases, but if there's at this point...
Спасибо большое. Many thanks indeed.
Thank you very much.
And once again, you're very welcome. Thank you very much. Дорогие коллеги.
Dear colleagues, today we build up our session in the following way. We have a multi-layered session, if you may. Professor Kalvianin told us about main principles of diagnostics and treatment, but we would like to make our session as close as possible to the clinical practice and to what you face and experience in the practice. Lev Brylov, PhD of Medical Sciences, head of the Neurological Department of State Budget Institution of Buyanov. Our institute works constantly together with him and with other specialists from Buyanov clinics. Today we will ask Mr. Brylov to show us a few cases from absolutely our basic clinical practice of the recent year. And we will ask Professor Kalviainen to comment on some of these cases, and then Professor Kalviainen will tell us about the specific cases in the second part of our symposium. Please, Lev, you have the floor. Good afternoon, dear friends. Many thanks to organizers for this kindly invitation to speak at this symposium. It's a big pleasure for me to be here with you. I should tell you that all these cases which we share with you were diagnosed and discussed and treated jointly with NPC Psychoneurology and Buyanov Institution. First, I will show you the video of two patients without specific description and detailed description of disease progression, and we will ask Professor Kalviainen to comment on the myoclonus. The colleagues, please, according to the ethical norms, it's a big ask to journalists who are present here. Please do not show the faces of patients. These faces are not to be posted on the internet or somewhere out of the medical audience. Please, all these presentations, atmosphere, everything, but not faces of patients, please, because of some ethical rules which we have to abide by. Yes, please. Once again, as Professor Calvianin already pointed out, even in our clinical picture, myoclonus should seem an insignificant sign. Nevertheless, they have a sign of a serious syndrome, and they give us the opportunity to break the diagnosis. First patient came to these involuntary jerks.
И вот профессор прокомментирует.
Perhaps the professor could comment what can we say in this regard by looking at his arm. So this is a 70-year-old male patient, and he had this involuntary jerk reaction of his muscles. Yes, if you could comment on what you see.
I think it's very difficult from this right away say that this is myoclonus. So it needs to be also and especially you cannot say right away without any examinations on what level it comes. So it could be cortical and it could be spinal and needs to be, of course, evaluated more. And but I would say that it's very suspicious for me that it would be from the level from cortex to spinal at whatever level, and needs to be very seriously taken symptom, I would say. And if I would see this in the clinic, I would start to looking with a very wide investigation. So I would take it seriously, this kind of symptom, when it continues. But it's from the video, it's impossible to say direct the level, but a symptom to be taken seriously, I would say.
Thank you very much. Thank you very much again. And the next case.
And we are moving on to the new case. Here, the situation is more definite. You see, this is the patient, 21-year-old patient. She would fall unconscious, and she had experienced it within 8 years. And besides seizures that she had, we also identified the movement of eyelids that you can see, and we would like to ask a professor to comment. But here with this diagnosis is more or less clear. However, we would like Professor Calviani to comment on what she sees as well. So pay attention to the fact that this is something what you may miss in everyday life, especially if you do not look at your patient attentively. So it is very important in urology to understand what you should be looking for and what you should pay attention to. So the floor is yours, Professor.
Yeah, I totally agree that this is a very good example that when patient has epilepsy, it's also important to still not to miss signs that can be seen in the office. And now this patient is having eyes closed, but in the eyelid myoclonus epilepsy, which this seems to be, sometimes you can also see the myoclonus of the eyelids when you discuss with the patient, and when the patient is really clearly conscious and discussing quite normally, still the eyelids are moving quite well, and you shouldn't miss that. And that might hint to when you have this differential diagnostic difficulty, whether the epilepsy is focal or generalized, and these patients often have generalized tonic-clonic seizures, and you think that you need to differentiate between generalized epilepsy and focal epilepsy, where there are very rapidly generalized tonic-clonic seizures. This might then give the hint towards the direction of generalized epilepsy and towards the right medication, because of course this myoclonic symptom and the whole syndrome again is exacerbated with the sodium channel blockers and shouldn't be treated as focal epilepsy. So very good to see this kind of sign which helps us in the diagnosis.
Спасибо большое.
Thank you very much. And we will show you 2 more clinical cases. It will be shown by Leo. And we also will ask Professor Calviani to comment on what she will see. Yes, at our department, in our clinic named after Buyanov, we have patients with different diseases, but we focus on autoimmune diseases or on diseases associated with autoimmune problems. So I will show you the case. It's a male patient, 41-year-old, and it's known that in 2017 he was bitten and then he was treated against meningoencephalitis, and then 2 weeks later, anyway, the encephalitis developed, and they identified antibodies of M class. The patient underwent a full scope of examination, was provided with a proper treatment of encephalitis, and he could see that his condition improved. Because as the disease progresses, he had some seizures, tetraparesis, the strength of hand muscles and foot muscles went down, and this all the data he provided to us verbally. Anyway, after treatment, he could feel certain improvement. The muscle strength improved. However, again, in 8 weeks, there was a second wave of his condition exacerbation, and there was an onset of twitches or jerk reactions, and myoclonic reaction was observed, and he was offered combined epileptic therapies. So this is a patient that has a second wave of symptoms that developed in 8 weeks after the onset of encephalitis. So despite the treatment of epilepsy, the seizures continued, and in a year and a half, the clinic of First Medical University suspected the autoimmune nature of the disease, of secondary disease, I would say, so autoimmune nature of secondary disease. So we are talking again then due to a certain degeneration in brain, secondary autoimmune lesion of nervous system may occur, and that's per the second wave of the disease. So that is what we suspected. So we did lumbar puncture, and we identified second type of tractal synthesis. And after the therapy, we saw no effect, and his condition was pretty much the same. We did several MRIs, however, we saw no pathological changes, and he received the maximal dosages of medicines for treating his epilepsy. So it was valproic acid, levetiracetam, clonazepam, and then he finally was admitted to our hospital. where we carried out an additional blood test for various antineural antibodies that could cause this autoimmune encephalitis as a secondary damage of the brain. We did not identify any antibodies, and now I would like to demonstrate you the clinical picture image, and this is a graphic description. You will see the video. So he suffers from dysarthria, spastic tetraparesis, and twitching, and also jerk reactions of hands and feet that would intensify after a certain stimulus or touch. So here you will see how it looks like. Sorry, I probably should push a button. Can you play the video to us right now? We checked it earlier and it should work. Can you open the folder, please? Can you open the same folder and you will see there the video. Well, it's a typical situation when during the symposium the video that played well during rehearsal would not play. However, our doctors are here. No, it starts working, you see. Okay. Here you see involuntary muscle contractions, myoclonus, that is provoked by touch. And so you see that it spreads along the body and it covers not only the arm muscles but also face muscles and trunk muscles. The patient's condition is very severe. He cannot service himself. He needs care. He lays down most of the time. So you see with an attempt to put him in a vertical or sitting position, the contractions intensify. Basically, it is quite impossible to offer full-scale rehabilitation. So you can see he cannot hold the vertical or sitting position, not due to weakness, but also to contractions. As Professor Kalvianis said, that these contractions can look different at home and in hospital. At home, he feels more comfortable. Contractions are not so bad, and so he's more active. So you can see that it covers, so contractions go almost continuously. So as for ECG, I think we should get back to the previous presentation. Yes, here is the previous slide. You see here my graphic artifacts. However, we see the electrodes in green are electrodic ones, so we see caudal distribution of contraction, and that makes us think that it is a cortical myoclonus. We also see spikes in the left hemisphere, in the lobe frontal sphere, and again, I told you that MRI showed us no changes whatsoever. Okay, you see the spikes and you see caudal distribution of contractions that we observed while watching the video. Therefore, we see focal cortical myoclonus. Here the table shows you the treatment options. that may be efficient, but this will be another separate discussion. So basically, it is epilepsy partially continua that developed due to tick-borne encephalitis, or additionally caused by the autoimmune damage, but we were not able to prove that 100%. However, we believe that it could happen. So on my side, I would like to emphasize that in this case, it is very important to remember that there is a great number of descriptions of similar cases. So due to tick-borne encephalitis or other type of encephalitis, so there are autoimmune encephalitis that have to be treated with autoimmune medicines. And secondly, Professor Calviani will comment what methods of treatment are possible in this particular case. Additionally, in order to decrease the number of seizures, and we hope that we will be able to offer some efficient options to these patients.
Okay, thank you very much for this excellent case, which I think it was also very informative and educational related to what we talk about and with what I presented. It illustrates very much these challenges that we have in treatment of these patients and in diagnostics of these patients. Regarding the treatment, now we have cortical myoclonus and as you said, epilepsy partialis continua, and but still, because the phenotype is myoclonic, I would stick to the, as you say, to those pharmaceutical treatments that are sort of broad spectrum drugs. Not you could try focal treatments, because it seems to be very left side, I mean right-sided focal, but there is really a risk that it will exacerbate also those jerks. So in addition to those medications that are mentioned in your table, at the moment we use a lot of globazam, which is frisium. I know that it's not so easy to use it here in Russia, but perhaps in future that might be an option. Sometimes in very difficult cases I also use clonazepam plus globazam. There might be some additional benefit of using them both. The influence is a little bit different with them. Then perambanel, which is Fycompa, which is an AMPA antagonist, AMPA receptor antagonist. It's also useful, which might be, so these might be still different approaches apart from those mentioned in the table, in the slide. But then, of course, this seems to be a very difficult situation. So we already discussed about the possibility of neuromodulatory treatment, which in this case might be vagal nerve stimulator, and that might be something to think about in this case. So that's in addition to these anti-epileptic drugs, could be, and of course, why not a deep brain stimulator might be also a possibility. So neuromodulatory treatment in addition to anti-epileptic drugs. So, but of course, that doesn't. These treatments doesn't. The situation of the patient is going to be difficult in any case. Even if we remove some of the myoclonic jerks, he still have this tetraparesis and so on. But of course, it would be very important to still a little bit influence on the difficult situation. So, but I agree with you that it's very important to remember these kind of post-infectious situations. Also, as I said, there are many cortical problems that cause this kind of situations.
Thank you very much. Спасибо большое. И второй случай.
Thank you very much. Our second case to review, please. The second case is the situation when we had a syndrome based on myoclonic fits. We went over to the diagnostic of non-neurological disease endangering the life of the patient, and we were able to diagnose it and to make treatment together with our colleagues. Let's wait for the presentation. It is about female patient, 44 years of age, who applied first to physicians with the ache in the shoulder and subfebrile temperature and enlargement of lymphatic nodes. She didn't receive a proper examination and diagnosis. Well, in January 2018, lymphatic nodes with some fever, then neurological symptoms in terms of hand jerks and hypertonus in the right hand. MRI was carried out and it showed norm. The patient was considered as functional disorders and movement disorders. He was admitted to NPC neurology, and epileptologists and other specialists carried out more in-depth examination by seeing myoclonic symptoms on the subject of autoimmune treatments, diseases, and she was sent to our department where we repeated MRI without significant clinical changes, and then we saw diffuse changes. First, I will show the patient what we saw during admissions. The psychiatric initially sent to the hospital with alleged functional disorders, and you can see from here such myoclonic contractions in her arm with the hypertonus of muscles and some painful contractions. Myoclonic of mouth muscles. Myoclonic oral muscles, and the patient was fully conscious. She was able to answer questions, to react. And at EEG picture, only diffusal slowing, EMG artifacts without any signs of cortical myoclonus. And we consider it as subcortical myoclonus, so the young patient with the onset of disease in the hypertonus in her arm and subcortical myoclonus in arm and oral muscles. MRI showed alterations which were considered as not significant clinically. Initially, there was an alleged reason for myoclonus, but it didn't confirm. And while testing of antibodies, positive analysis for anti-RI. In this case, it's a clinically significant combination of such manifestations and it tells us that we most probably have to do with the paraneoplastic autoimmune process picture, which was started with initially oncological disease, and with such antibodies, specifically anti-RI more than 50%, means that we have to carry out in-depth onco-screening, just not to miss oncology as a trigger of this disease. You see the breast cancer is found in 50% of cases with such amount of these antibodies. The patient was sent for PET-CT. In the rest mammal gland, we found a tumor and metastasis in the bones. After that, she underwent chemical treatment, and her oncological disease was stabilized. We see now that the initial increase of lymphatic bodies was the sign of breast cancer, which was not diagnosed at that case, and practically this cancer started from the neurological picture. It happens sometimes in our practice. We had such cases, and in this audience I'd like to repeat that specific antibodies and neurological picture might be a very important and serious signal for oncological screening, because oncologists sometimes refuse us in this screening without seeing the articulated signs, and they say that our suspicions are not true, but we sometimes prove that we were right. After treatment, this patient underwent few courses, few cycles of sphemide, monthly cycles, about the autoimmune encephalitis as a complication of oncological disease. And as we see, we monitor this patient quite a long time. It allowed not only to save life of the patient and prolong life of the patient, but also to keep some normal life for this patient. Although the status is quite severe, I'll show you another video. What happens now currently? Well, but just to finish the treatment, she receives carbamazepine and clonazepam. In this situation, atypical picture that carbamazepine was not effective. Carbamazepine provided some positive situation, which is not typical for myoclonic manifestations. That was the final video. You see she can walk. She has some myoclonic fits. Can you repeat the video, playback the video once again? Well, nevertheless, she can use some objects. Of course, she needs some help. Quite severe situation in the normal life, but to some extent he's curable. We can treat such patients, and the treatment allows to stabilize their status. And well, here I'd like to ask for the comments of Professor Kalvianin on the treatment.
Again, this was excellent case and really emphasizes the value of neurological signs, sometimes very bizarre signs to be taken seriously as a paraneoplastic signs and symptoms. And I have the same experience that our colleagues in oncology or general medicine don't take us seriously sometimes when we try to emphasize the value of oncological screening for these patients, but this was excellent case in that sense. I wonder, could it be the issue that she had already bone metastasis, that this is still, the process is active, and to a certain extent, although it's stable, and which could cause then the also these neurological symptoms to be so severe? Could it be that because sometimes these paraneoplastic neurological signs they really decrease when usually when the cancer is treated. If it's really treated, they go away or at least diminish, and then they activate again if the cancer relapses. So it might be that there is still some tumor activity, even if it's not in the primary tumor, but if it's in the metastatic tumor. Have you thought about that?
Yes, we repeated PET CT and it was negative for tumor activity. So.
Okay. So that's my first point, that sometimes these paraneoplastic neurological symptoms, they relate to the tumor activity, and that's also to be taken seriously. But let's assume that tumor is now stable, and so we need to now treat the symptoms. So there are, of course, cases where sodium channel blockers, and in this case carbamazine, doesn't worsen, but still I would usually go with the idea that broad spectrum drugs, and I would use then valproate, clonazepam she had, but valproate she didn't have. I would try what valproate would do it. Now I think we don't need to be worried about the teratogenicity of valproate in her. Also, she's a fertile-aged woman, but probably she's not going to have children. So with contraception, valproate could be tried. Higher dose of levetiracetam, perhaps also for her perampanel. Then, if levetiracetam is not tolerated because of psychiatric adverse effects, then privaracetam is one of the options also, if that's available. But these lines of drugs. Then about the autoimmune treatment, you used, I understood, cyclophosphamide. Do you have rituximab? So that's sometimes what we use in these cases. So if autoimmune treatment is needed, that might be an option to try. That's my comments.
Thank you very much, Reta. Thank you, Lev.
And, this is an excellent talk about the specific forms of syndromes that could be extremely difficult in terms of diagnostic and differential diagnostic. Yeah, Lev.
So then last part of my talk, I tell you a little bit about progressive myoclonus epilepsies, which is one group of diseases that also cause difficult myoclonus, and then if we have time, a little bit about treatment of myoclonus in general. So progressive myoclonus epilepsies are rare and heterogeneous disorders, and defined by a combination of usually action myoclonus. So myoclonus is caused by movement, and then these patients have epileptic seizures and then some sort of progressive neurological deterioration. So, and this could mean progressive cognitive decline, ataxia, neuropathy, or myopathy, or all of these. And progressive myoclonic epilepsies are then in middle of a sort of spectrum of diseases. So younger patients could have in early infancy starting progressive encephalopathies, which are associated with seizures. And then we also have in adults progressive myoclonic ataxia diseases, which could also include seizures. So these are usually, for example, mitochondrial diseases and spinocerebellar degeneration or celiac diseases that could be called progressive myoclonic ataxias. But there's a huge, quite a large group of progressive myoclonic epilepsies where where the disease starts with myoclonia and tonic-clonic seizures in late infancy, childhood or adolescence. And these have been described already in late 1800 by Unverecht and Lundberg. Unverecht in Estonia and Lundborg in Sweden, and then Lafora in Spain. And the main diseases, for example, when I went to medical school, were this Unverecht-Lundborg disease, Lafora disease, then we had neuronal ceroid lipofuscinosis and mitochondrial disease. So there were 4 major progressive myoclonic epilepsies, groups of diseases. And EPM1, Unverecht-Lundborg disease, was not so progressive, and the others were very progressive diseases. A couple of years ago, I wrote a review article about progressive myoclonus epilepsies, and at that point, we already had about 10 different EPM1s, so progressive myoclonus epilepsies, number 1, 2, 3, 4, and so on. So we have been recognizing more and more numerous progressive myoclonus epilepsies, especially when the genetics, molecular genetics, have involved. And then during the last years, there are even more. I would say at the moment at least 14 different entities that can be saying that can be defined as being progressive myoclonic epilepsies. But I'm going to concentrate now mainly as an example, the hallmark, the first recognized progressive myoclonus epilepsy, Unverecht-Lundborg disease, because I know it best. I make a lot of research about it, and it's a very good example of progressive myoclonus epilepsies. So it was described by Unverecht in 1891 in Estonia and by Lundborg in 1903 in Sweden. It's autosomal recessively inherited, and age of onset varies from 6 to 16 years. And as I said, it's there's action activated and also stimulus sensitive myoclonus. You saw a couple of videos of these patients already earlier. And then gradually these patients get also atactic. They have incoordination, intentional tremor, and dysarthria. And part of them are then later on wheelchair bound. There are places like in Finland where EPM1 is clustered, but there are patients all over the world, and there should be also patients in Russia, especially near Finland, and I think this probably is underdiagnosed also here. So therefore this is important to talk about when we now have genetic diagnosis possibilities, which could make it clearer also for the patients and the families if they have the proper diagnosis. And the genetics is such that there is a cystatin B mutation. The most common mutation is expansion mutation, and for example in Finland most of the patients are homozygotes for the expansion mutation. But then, for example, in Finland, we have some patients that are compound heterozygotes for the rare stop mutation. So they have expansion mutation in the other allele and the rare stop mutation in the other allele. And that gives them a more severe phenotype. But it could be any kind of other combination. So you should also look for other than the expansion mutations now when we know these other mutations also. But this can be so, the disease can be diagnosed by genetic analysis of the mutation. And how does this disease then manifest clinically? So at birth, these children are normal and they develop until 6 to 16 years quite normally. Then they start to have either tonic-clonic epileptic seizures or myoclonia, which can be very mild in the beginning. So the first phase of the disease is exactly like juvenile myoclonus epilepsy, and many of the patients have their first diagnosis for years and are treated as juvenile myoclonus epilepsy patients. And this might be the way that you, in your clinics also you have sort of difficult juvenile myoclonus epilepsy, drug-resistant juvenile myoclonus epilepsy patients that in fact have this EPM1. If you have never diagnosed it so you just think that this is very severe patient with juvenile myoclonus epilepsy and don't think about it. But then some of these patients, start to have these more neurological findings, which juvenile myoclonus epilepsy patients shouldn't have. They shouldn't have any neurological findings in the neurological examination. So they start to have more myoclonus also in the daily activities and more ataxia but some of them are very mildly disabled. They can walk still, and this is the group of patients that might be undiagnosed. Then there are these more severely disabled patients that are more easily diagnosed. We have refined the phenotype of Unrecht-Lundborg disease from Finland a couple of years ago because all the literature was quite old, and we wanted to really show what's the current phenotype and as I said, the frequency and the of the disease is it's most frequent in the whole world in Finland. So we have the largest cohort in the world in our center. And for example, we have seen that the younger age at onset and longer disease duration correlates with the disease severity, and we have been looking at some other things. The sad thing for the patients, on the other hand, is that regarding, although the motor problems progress, the verbal memory stays normal, independent of the disability, and sometimes that's very hard for them, and that causes also depression. We have also done a lot of imaging studies, and we can see, for example, that cortical tingling and volume loss of sensory motor areas correlate significantly with the disease severity. With the other mutations in the other countries, it has been also shown that the disease severity inversely correlates with the amount of functional cystatin B protein. So this is really the cause of the disease, although no causative treatment has been at the moment found. So it's only symptomatic treatment that we can offer at the moment, but this is what we are investigating at the moment. So you can see this is a patient that has the null mutation, so there is no cystatin B in the brain with this patient, and the phenotype is much more severe than the normal EPM patients with the expansion mutation. Then a couple of words of the other progressive myoclonus epilepsies. So the second classical progressive myoclonus epilepsy is EPM2, which is the Laffer disease. And the difference compared to EPM1 is that this is very rapidly progressive with dementia and apraxia and visual loss. And all these patients become very rapidly incapacitated, and they usually die within a decade of symptom onset. Whereas at the moment, EPM1 patients, at the moment we have looked the epidemiology in Finland. The mean mean life. The EPM1 patients at the moment live until the 60th year of life at the moment. So there's clear difference in this. Then there are these neuronal ceroid lipofuscinosis, CLNs, which usually were earlier just divided into infantile, juvenile, and adult according to the age of onset. And again, this is a group of diseases which all lead to early death. So again, different from EPM1, which usually doesn't lead to early death. But after the molecular genetics has emerged, we now recognize at least 14 genetic forms and at least 360 etiological mutations for this neuronal ceroid lipofuscinosis. So this field has really changed a lot. But again, myoclonic seizures may be infrequent in the beginning of these diseases, but however, in the end of neuronal ceroid lipofuscinosis, nearly all these patients have myoclonus, and which correlates to the brain atrophy, which then progresses in the end of these diseases. So therefore, neuronal ceroid lipofuscinosis nowadays, we think that they belong to the disease group of progressive myoclonus epilepsies. And this is important in that sense that there is now an opening of treatment to one of these diseases, which is the CLN2, which is called also pattern disease. And nowadays there is already one treatment which is given intracerebroventricular by intracerebroventricular infusion, and it's called cerliponase alpha. Expensive and complicated treatment, but there is now causative treatment and which personalized medicine that can be used in this particular mutation and particular type of disease. Unfortunately, for example, in Finland we don't have this CLN2 disease, whereas we have more frequently than anywhere else CLN3 in our Finnish disease inheritance. So at the moment we are trying to find out treatment for this CLN3 form of neuronal ceroid lipofuscinosis, and that's some of our interest focus at the moment. So just to show again one example of EPMs, there's EPM6, which was recently found from the North Sea area, so Denmark and Netherlands. And there might be this kind of new EPM diseases in certain areas. So there are still a lot of progressive myoclonus epilepsies that have not been recognized, and there's also research. This is a research area that should be looked at, and for example, exome sequencing might help in that. One of the new EPM1s is a myoclonus epilepsy and ataxia due to a pathogenic variant in potassium channel, and this was just found a couple of years ago by investigators with a group of Finland participating also in this. So this is my conclusion from the progressive myoclonus epilepsies. There's a huge amount of different kind of usually genetic disorders behind these progressive myoclonus epilepsies, and if there's a meaningful cognitive deterioration in the syndrome, then you should think about either Lafora disease or some of the neuronal ceroid lipofuscinosis. But if the intellect is essentially preserved, then the most common one is EPM1, Unrecht-Lundborg disease, which can be easily genetically tested. And then there is quite a huge list of different kind of very rare syndromes, which are some of the mitochondrial diseases, then these rare EPM 4 to 6, and then some of the other diseases. And then there are also some new diseases. There could be even a new Moscow type of EPM, which should be looked at. And then during the last minutes, I could talk about a little bit still about the treatment of myoclonus. We haven't yet talked about the physiological myoclonus. So all of us probably know when we are going to sleep, we sometimes have this myoclonus, which is called hypnic myoclonus, and that's physiological. And sometimes patients also complain about that, and sometimes clonazepam can be used for that. But otherwise, as already said, we could use for cortical, subcortical myoclonus, the treatments are, as said, valproate, clonazepam, clobazam, levetiracetam, topiramate, and zonisamide. These were already also in Lev's slide. And then these sodium channel blockers and then also GABAergic drugs should be avoided because they can use paradoxical worsening. Lamotrigine was recommended some earlier for use in myoclonus, but then, for example, in Dravet syndrome, it was noticed that it can worsen in epileptic myoclonus, and there is also, for example, this article which shows that it can worsen myoclonus in unraised Lundborg disease. So we don't recommend lamotrigine at the moment anymore for myoclonus in general. These are the doses that we use, and you can see that they are quite high. So for example, for levetiracetam, sometimes we use 4,000 milligram per day, so it's quite high, but that means that then sometimes the patient can get psychiatric adverse effects, and then that might be a problem. Also for topiramate, cognitive dysfunction sometimes is a problem, or with zonisamide, psychomotor slowing. And with valproate, of course, we need to remember that you cannot use it with mitochondrial disease, or if there's especially POLQ mutation, and then teratogenicity, of course, sometimes needs to be taken into account. I mentioned already brivaracetam, which is a newer form of levetiracetam, and we have made a really randomized double-blind placebo-controlled study with brivaracetam in unraised Lundborg disease. The study was negative, but I believe really that brivaracetam is a very good drug in myoclonus and also in unraised Lundborg disease. But the problem was that the UMRS scale was not very good measure for the efficacy, and that's the reason why, as I said, we are now developing better measurements for treatment effect, and that's the problem with these trials. The doses should be 50 to 100 milligram twice a day. Then perampanel has been studied in unraised Lundborg disease, so this is Fycompa. And there it could be that lower doses than with focal epilepsy is enough, so 6 milligram once a day might be enough, whereas sometimes in focal epilepsy we use up till 12 milligram per day. This is also a perampanel trial in Lafora disease, and there was very good effect. Then I think piracetam is widely used. So sometimes this helps. So adding piracetam even to levetiracetam is something that we use in difficult cases. So also in these cases that we saw, this might be something to use. Again, already, even if you use levetiracetam, you can add piracetam, and that's something that can be used. Rarely, sodium oxybate and alpha-5-hydroxytryptophan are used, but personally I don't believe that they are very useful. But I need to mention them because they are always mentioned in the literature. Then vagal nerve stimulator and deep brain stimulator are something that are used, but considering there are different etiologies, tailoring of the deep brain stimulator to the symptom is difficult. As compared to, for example, Parkinson's disease, this is totally different thing. In negative myoclonus, which we saw also in the video, ethosuximide, which is one of the old anti-epileptic drugs for absence seizures, ethosuximide can be tried for negative myoclonus. And we usually don't treat post-hypoxic myoclonus, but nowadays when treatments are more and more effective, and there are also patients who survive after resuscitation, so this might be a problem. So then again, combination of levetiracetam, valproate, and clonazepam is used also for these situations. Emergency treatment of myoclonic status epilepticus, where myoclonic jerks exacerbate, leading to a series of jerks or status epilepticus. Then it's benzodiazepines, intravenous valproate or intravenous levetiracetam or intravenous brivaracetam, but anesthesia should be avoided. And this is my last slide, again putting together all these treatment options for cortical subcortical myoclonus. So broad spectrum anti-epileptic drugs, and then VNS or DPS. And unfortunately, we don't have very good drug options, so we really need development for treatment. Thank you.
Thank you very much, Rieta. It was really fascinating talk. Thank you very much indeed.
Dear colleagues, maybe we have time only for one question, and the answer should be within 1 minute, and we should wrap up our talk. Well, all publications, or at least many that were mentioned by Professor Calviani, are available, and you can familiarize with them. Once again, I would like to thank you for your attention. I would like to thank our lecturers, Professor Calviani as well as Lev Brilov. Many of the points mentioned in this lecture indeed were unique. So I'm very happy that you joined us. It was a unique talk, and Professor Calviani is a unique expert when it comes to myoclonus and myoclonic epilepsy, and cases that were demonstrated by Lev Vadimovich, especially the one with tick-borne encephalitis. This is something what I have never counteracted in my practice. It's a unique case. One in a time. Yes. Just 1 year, one case in your practice, and the only one that you demonstrated. So, again, unique case, and you know that right now the situation with tick-borne encephalitis exacerbates. Once again, thank you very much. And in half an hour, I invite you to attend a symposium in Mudrov Hall, where you will hear many presentations given by colleagues from our center, and we will talk about different brain damage and brain diseases. So we will be happy to see you there. And on the 1st and 2nd of April, we will give conference at the hospital named after Buyanov, and we sincerely hope that Professor Calviani will join us, and we will demonstrate lots of practical cases. And many colleagues that you have seen our video, these are leading specialists worldwide, and they will be there as well. So we are not saying goodbye to you. We will see you in half an hour at Mudrov Hall, and see you in April as well. Thank you very much.